have two eminent speakers in that field. I would like to introduce our first speaker, Professor Linda Miller. She will give us our first lecture. And over the second lecture, I will introduce the second eminent speaker in our webinar. To speak about Professor Linda Miller, she is a founder and clinical director of the Breast Cancer Physical Therapy in Philadelphia. Over 20 years experience. She had more than 300 hours in training of lymphedema. So we are squeezing all the lymphedema tips and tricks and multiple scenarios for you over the next 1.5 hours. She also have managed lymphedema in multiple countries. She had training in United Kingdom, in Italy, in Spain, in France, in Australia as well. So she grasped multi-nationality, how they manage the same clinical problem and what is the variation between them. She also in 2020 have established a cancer rehabilitation program in Sultan Qaboos University in Oman, in the Middle East. And they were very eager to have her as a permanent staff, and they offered her to have edema management unit in that university in the Middle East, and obviously will be delighted to have her expertise in our area of the world. I would like also to give a glimpse of introduction to our panelist, which is a dear colleague, Tracy Green. She is very well known nursing in that regard. I will definitely introduce her fully after the Linda lecture in order not to take from your time. And the mic is to you, Linda. And if you have any questions regarding attendee, please put us on the chat and we will try to answer all your questions. The mic is yours, Linda, and we're eagerly to listen to your expertise. Please go ahead.
Thank you very much. I want to just make sure I'm able to share my screen. Okay. Slideshow from beginning. Okay, looks like we're okay. All right. Hello, everybody. I'm very, very privileged to be able to present some of the latest evidence and clinical applications that we know with regards to breast cancer lymphedema management. I think we've all seen lots of different types of or presentations of breast cancer lymphedema. Sometimes it's just in the hand, sometimes the full arm. We see limbs that are distorted in shape. We also can't forget chest wall and breast edema. We've seen limbs with infection, and we've seen limbs with active disease. So in order to be able to effectively treat all of these, I would like to begin by saying that a good understanding of breast cancer treatment management, including chemotherapy and radiation therapy, is critical to being able to sexually treat these patients. Also, this particular patient also has active disease. The lymphedema in her case is only in her ear. She is a breast cancer patient. So I'm going to start with the basics, but we're going to assume that most of you know a lot of this information. One thing that's a little different in the later literature of the last 10 to 12 years is that lymphedema is an accumulation of high or low protein fluid. The view was always that it was high protein. Some of the newer research that's come out actually says that it's a low protein dysfunction as well. We're familiar with the limbs where we can actually push and have limited mobile tissue fluid. We can actually get what we would call pitting edema. We also have the low protein fluid. Again, this is a relatively new definition of lymphedema in that it can be high or low protein. Breast cancer lymphedema can be transient or persistent, really depending upon its time of onset and the etiology. whether it be chemotherapy related or whether it's radiation induced. So that's something that gets teased out the more you treat the patients. Chronic edema and chronic inflammation leads to actual morphological changes in the lymph vessels. So we actually see dilation and collaterals that form. There's long-term changes in the subcutaneous tissue. We've got increased fibrin, basically increased scar tissue in the interstitium, and we've got decreased mobile tissue. So the longer that edema persists, the less fluid there is and the more fibrotic tissue there is. And that impacts how we then treat the limb. It's also been shown to be fascial thickening along the line of the fascia. So there's a lot of changes in the tissue that need to be addressed. So a relatively new, and when I say new, probably in the last 12 years or so, is something that's the revised Starling's principle, which is that all edema is lymphedema, and it develops along a continuum of lymphatic insufficiency or lymph drainage failure. So the old Starling's law was 90% of resorption happens through the venous system, the other 10% through the lymph system. Some further and better diagnostic imaging has allowed us to see that actually all absorption, all resorption occurs through the lymph system. So all edema is some type of lymphedema. Breast cancer treatment, is the leading cause of secondary lymphedema. Just want to briefly go into the pathophysiology. Again, this is because based on the pathophysiology, that is from where our treatment originates. So we know that for sure breast cancer lymphedema occurs as a result of lymph drainage failure. And I know other speakers will address the idea of taking lymph nodes out, further radiation therapy causing a problem. There's also a hemodynamic imbalance that's at work in breast cancer lymphedema that has also allowed us to dictate some new and innovative treatments that sometimes had been controversial. I like to borrow this schematic, which I adapted from Dr. Peter Mortimer, who's from England, from the UK. It's a basic, simple description of lymph drainage failure. So if you obliterate your lymphatics, you take them out, or you obstruct the lymphatics with scar tissue, with tumor, as we've seen in the one picture, you actually end up with lymph drainage failure. And there are a lot of very well-known researchers that have documented this over time. There are, however, hemodynamic imbalances in breast cancer lymphedema. It's been shown that up to 70% of women with breast cancer lymphedema have documented venous insufficiency in the limb. Okay, so not only is there an impairment or possibly an impairment in the lymph system because of the surgery or procedures they have, many of these women will also have venous outflow problems. And this was actually first found and documented back in 1938. Many of you might see with your patients some what looks to be venous varicosities. Here we have one on the woman's chest wall. That's her involved side. And here's an upper extremity patient, relatively new post-op. She still has her covering over her mastectomy site. And you can see the collaterals in the arm already to be working hard. The question has always been whether the lymphedema causes the venous outflow problems or whether it's the outflow problems that precipitate the lymphedema. I think the jury is still out on that, and I suggest that those of us to treat the patient, it doesn't particularly matter which causes which. If we know it exists, then we can treat it. Because of this venous outflow problem, we end up with net filtration into the interstitium. So what does that mean? More fluid actually going into the tissue, putting an increased burden on the lymph system itself. Just to, again, to hit the point, I've got references, and anybody wants to tap me at the end for references, a full list, I'll be glad to provide. But we have more recent data that talks about arterial and venous outflow problems or inflow problems on both sides of the limb. So it could be a predisposition to have lymphedema hemodynamically before somebody even has surgery. That could be a problem. There could be increased capillary filtration in both forearms of patients. So I think the bottom line is there's a lot more going on besides just lymph drainage failure. And I actually asked Dr. Mortimer if I could revise his schematic a little bit. And if we want to totally look, excuse me, at how to treat and manage breast cancer lymphedema, we have to focus on not just the lymph system, but the increased filtration that's happening because of different reasons. Some identified, some not yet identified. In terms of what we want to do to achieve a good breast cancer management program, we talked earlier about the fact that there's a lot of morphologic tissue changes that occur as a result of chronic edema and inflammation. And so just reducing fluid volume is not enough to get a sustained tissue change. So one of the things that we want to do, and that varies depending upon what modality we're using, is we want to soften the fibrous tissue by applying pressure. And as therapists, we know this. We're doing transverse fiction massage over scars. Our burn victims will be wearing compression garments to manage fibrosis, or fibrin of the scars. So essentially what we're actually doing is scar tissue management for these very chronic edemas, which is why some of the literature that we're going to talk about in the future of the presentation talks about maybe using higher pressures. The other thing that we want to do with our program is we want to get rid of that excess accumulated tissue fluid. So we know that lymphedema has a fluid and a protein component. So we need to manage the protein component by applying pressure, as well as the increased filtration, which is causing the increased volume. That is also managed by changing tissue pressure, maybe manual lymphatic therapy, applying a bandage and having the patient exercise, or simply by applying a compression sleeve. In terms of long-term changes, our job is to teach the patient how to manage and continue to minimize that excess filtration that they may have physiologically that's going on. So we can assume that at least 50%, if not 70% of our patients have not just lymphatic failure, but some sort of hemodynamic issue, which is causing more filtration into the tissue. So what are some of our treatment options? Obviously, exercise, lymphatic flow increases with movement. We're going to just name a few here and then go through a little bit more detail. Compression is probably one of the cornerstones of lymphedema management, and that can be in the terms of multi-layer bandaging or compression garments. Manual lymphatic therapy, massage technique that many of us have spent many, many hours learning, trying to learn to perfect. Intermittent pneumatic compression or a compression pump. And finally, there are new technologies and biologics. And the biologics is actually coming from the fact that people, even like Dr. Mortimer, are looking at some of the genetic components of lymphedema and are able to look at maybe if somebody has too much vascular anterior endothelial growth factor, there's a way to shut that down. So again, that's a little bit above my pay grade, but there are people looking at more advanced treatment techniques. To really understand how to treat, I think you need to recognize where the edema is. And again, diagnostic imaging has improved over the last 20 years or so. And so things that we used to believe were true perhaps are no longer. So if we have an image of soft tissue. We have the epidermis and we have the subcutaneous layer. Now, most of us were taught that our lymphedema treatments, especially our manual therapy, is supposed to be quite light, working on that very thin, superficial layer. And in fact, if we go too heavy, there's a chance that we're going to damage lymphatic vessels. Well, diagnostic imaging has actually shown us that the volume of fluid in the plexus that we are focusing on so often, that superficial layer, is actually only 2 to 3% of the total fluid that's retained. And as a matter of fact, most of the mobile tissue fluid is actually in the subcutaneous. So that begins to let us know that some of our treatment techniques may require more pressure in order to actually impact not just volume reduction, but also tissue texture changes. Manual lymph therapy is a technique that many of us have learned. I also would say that many of us have probably modified it throughout our clinical practice. The idea is that you are able to take lymphatic fluid from a congested lymphatome, change direction, move it across a watershed, and then take it to a place that's draining. And the way manual lymph therapy works is by changing tissue pressure. So when we do the massage, it's pressure on, pressure off, pressure on, pressure off. And whether it be a circular pressure, as say the Germans do, or a linear pressure, skin stretch, as well as the Australians do, it all relies on the same principle of changing tissue pressure. However, a lot of the literature that looks at manual lymphatic therapy has actually shown that it's not very effective. And that kind of gets people a little bit upset when we talk about this, because it's pretty much a staple of many people's treatments. But I ask the question, does that mean it's of no value? From the lab, we know that actually using heavier pressures may be more effective in treating lymphedema, and that the superficial lymphatics can actually handle more pressure than perhaps we thought they might have before. So some of the data that's looked at, some of the older studies that included manual drainage, may be looking at a subset of clinicians or studies that are using that light 20 to 30 to 40 millimeters of mercury that we might have all been taught, not realizing that heavier pressure may be more appropriate. So again, remember that most of that fluid, subcutaneous fluid, is deeper and requires higher pressure. So can we as clinicians modify our techniques? And what I would suggest is, I think intuitively we probably already are. We're going a little bit more firm on fibrous tissue to soften it up. This actually recently came off of LinkedIn. I wanted to put it in. It's from an Australian group. A recent study using particular lymphography shows that firm, slow massage is more effective than the previously effective gentle massage. So I think the word is beginning to spread. And if we look back to the pathophysiology and understand that there's a fibrotic component and that part of what we need to do is treat the fibrosis, it certainly justifies heavier pressures. In terms of compression, that can be anywhere from compression bandaging to compression sleeves. Obviously, you want to get the appropriate sleeve for the appropriate fit. There are Velcro garments, and we can't forget about our chest wall and breast edema. Applying compression bandages, if we start with that, especially when the muscle contracts, changes tissue pressure. And Professor Leduc from Belgium has actually shown us this. We actually increase tissue fluid resorption when we exercise with the bandage on. Systematic reviews of bandaging shows that they're very effective. And often they're used in the treatment phase. And I would say that because many times they're bulky and unruly, patients as well as therapists are pretty quick to try to end that part of the treatment and get into some sort of substitute compression. However, the research shows that those who continue to bandage for at least 3 nights a week after they have been discharged and they're doing their maintenance program actually have better long-term results. So as clinicians, perhaps we can come up with more effective ways to provide nighttime compression to actually get long-term benefits. Compression garments can be used to either treat lymphedema or to maintain results once the limb has been successfully treated. Again, in terms of the research, it's considered very effective in treating breast cancer lymphedema. There's a lot of research in breast cancer lymphedema, that probably more than in any other lymphedema. So it really does give us a lot of information to draw from. We can use these garments to affect that excessive filtration. Remember, we talked about lymph drainage failure and filtration that's happening. We can do some of our techniques to treat the fibrosis, but we've got to manage the filtration that's happening into the interstitium. The garment will actually help that. There was a study recently published, and I just want to go over briefly the findings. It'll be in your handout, but the bottom line is that significant improvement in arm lymphedema volume was noticed when you combine some type of nighttime compression as well. So wearing daytime compression plus various nighttime compressions can make a difference. We use exercise to change tissue pressure. And exercise can be performed with women who have breast cancer, lymphedema, or who are at risk. There's lots of literature on exercise, way too much for me to include in about 20 minutes, but actually all of this is a lot to include in 20 minutes, but I'm doing my best. One thing we've learned over time is that exercise does not have to be remedial, but we can actually use resistive and aerobic activities. We do know that we want to exercise wearing some type of compression. That enhances the muscle pump, and that's a critical part of the management program. It actually hasn't always been, though. I was fortunate to be part of a work group back in 1998 that actually involved some of the big hitters of the lymphedema world, Dr. Roxon, Drs. Foldy, Professor Leduc, Peter Mortimer, and there's Judith Casely Smith was involved, and then there's me. My main position, my main role of being in this group was to advocate for the use of exercise and not just remedial activity. And after several hours of discussion, I was actually able to get the group to put in these simple 5 words or 6 words. Exercise can include, but may not be limited to active range of motion, may not be limited to, open the door for us to be able to use more aggressive exercise. I don't want to go too much into prevention because I know that's going to be talked about, but I do want to say that wearing sleeves early on when lymphedema just begins to happen, actually is shown to be an effective management tool. Dr. Johansson from Sweden has done a lot of excellent work with both manual therapy and compression. And it's actually, her data has said that if somebody with mild edema wears a sleeve for about 6 months, it can actually control the edema, and they may not need to wear it further. So you titrate the patient down, and many of these women with very mild edema can go without compression long term. I want to finish just talking about intermittent compression. We know that pumps move fluid into the lymphatic system, and so therefore they help manage that filtration that we've talked about. Compression pumps and manual lymph therapy have different physiologic mechanisms, so they're not interchangeable. You don't say, well, I don't have time for massage today, I'm going to use a pump instead. They have different physiologic mechanisms. Remember, up to 70% of women with breast cancer lymphedema have venous insufficiency, so we can use the pump to actually improve or decrease the filtration. into the tissue. It's been shown in the literature that those with breast cancer lymphedema can use intermittent compression both in the treatment and the maintenance phase. Those women that use intermittent compression actually get sort of more better than those that don't and are able to maintain it longer. Just finishing up, in terms of pressures, again, we started this presentation talking about pressures. Literature suggests that intermittent compression gets better or more effective with higher pressures. We look at especially the more fibrotic limbs that we may be using compressor with, pumps with. High pressure leads to the long-term formation of tissue channels. So we're actually changing the morphology of the tissue. Faster cycle times also improve tolerance to higher pressures. This is one I want to finish talking with this particular slide. Professor Olszewski is a Polish lymphologist who's recently passed away, but has done some amazing work with fibrotic limbs. He actually determined that when you have a very fibrotic limb, you actually have to cut the amount of pressure or double the pressure based on how fibrotic the limb is. So most of the time our pump manufacturers are telling us to pump at 30 to 40. His work suggests that if you're pumping at 30 to 40, you're actually only applying about 15 millimeters to the tissue fluid. So his work shows that actually in really fibrotic limbs, you can pump up to 100 millimeters of mercury, and only 50 millimeters is being imparted to the limb. So you always have to consider the thickness or the fibrosis. Intermittent compression is always an adjunct to doing the other things we can do. And it can be an important part of the program. And the important thing is parameters are decided on a case by case. How thick is the arm? How large is the arm? Where is the edema? If I've got a programmable pump, I can pay attention to all of that. So to wrap up, we know that there's a lymphatic and a venous component of the edemas, and the most effective treatment program is going to be one that softens fibrous tissues, decreases excess accumulated tissue fluid, minimizes excess filtration. So we want to soften the tissue, get rid of the extra filtrated tissue that's in there, and then manage the extra filtration that's going to keep happening. Applied pressure is using various modalities, our hands, sleeves, a pump. We impact fibrosis and filtration, and therefore impact tissue texture and limb size. Best short-term and long-term outcomes are going to be achieved by addressing skin fibrosis and managing filtration. I want to finish just with a quote from Albert Einstein. He's one of my favorites. Imagination is more important than knowledge. If you know the pathophysiology of breast cancer lymphedema, you can be creative and figure out treatment techniques that are best going to manage it, especially in the long term. Thank you.
Thank you very, very much. That is really very enjoyable lecture, Linda. And I will take the poll question for the attendee, and then I will take all the panelists and the speakers and my co-moderators' opinion about such a great lecture. The poll question, I will read it loudly. How does a compression garment help with lymphedema? Single choice. Either by increasing blood flow to the affected area, by reducing amount of fluid build up in the affected area, or by reducing the amount of oxygen in the affected area. I think we have about 30 to 60 seconds to put your answer. Very important question regarding the garment treatment of lymphedema, and we'll see what the option will be. Hopefully we'll have it shortly, within few seconds, and then we'll take the opinion of my co-moderator, Bethany. Can we see the result? Yes. I was expecting everyone will get this one right. Yes, it worked by reducing the amount of fluid pull-up in the affected. I think we have more than 90% of the answer was correct. So let me start by my dearest co-moderator, Bethany, your comment about Linda, great lecture.
Linda, it was fantastic. I learned so much. I love all the different opinions and views that we can all learn from. My only question, or if you can expand just a little bit, because this is really the first time I've heard about the protein, I forget the exact wording you use, the opposite of protein-rich fluid, having the lower protein. Can you just like briefly expand on that? Because it piqued my interest.
Sure. Basically, because the thought was that, as I mentioned earlier, Starling's law was that arterial inflow is going to be equal to lymphatic and venous return. And with the idea that lymphedema was a high protein, there was basically something called a high protein edema, lymphedema, and a low protein edema, or venous edema. What we have now learned is that, and there are still people that use the term phlebolymphodema, blood lymphatic edema. But what we've learned with the modified Starling's law is that all edemas are lymphedemas. And that's why the edema can actually be a higher protein or a lower protein edema. Does that help at all?
Yes, great. Thank you so much.
Excellent. And my dearest Tracy Green, you obviously have spent a huge amount of time in NHS dealing with this problem. Your comment about Linda's lecture.
Thanks, Linda, and thanks, Dr. Omar. An absolutely fantastic presentation. I really enjoyed it. And like Bethany, I sort of have learned so many new sort of things that I hadn't thought of before. Just one thing that I would like to ask about as well. We know with ICG now that we can see some alternate drainage pathways as well. And I like the idea about you saying that you could be that we can get creative with our treatments. And I think ICG is one of these ways that we are really moving forward and realizing that for those difficult patients, or those that we were thinking, what are we doing? Why aren't we getting any results here? That obviously there are the alternate pathways. I just wonder if you could maybe expand on that for me, if at all.
I think I was first made aware of the alternative pathways by Professor Leduc, who did some wonderful cadaver work showing some anterior pathways, a posterior deltoid pathway. And that was very sort of primitive. As you mentioned, Tracy, we have some of the newer imaging. I think, as of now, at least, and anybody can comment, the literature it is not showing that we actually improve or that we can actually move along certain pathways and use ICG to actually direct our flow. So if you look at treatment that is mediated or using that fluoroscopy to determine our flow, the research right now anyway is not compelling. It might be at some point, but it's the technology is there, but the data is not there yet.
Thank you. Yeah.
Okay, that's great. And I would like my dearest next speaker, Professor Vincent. I'm sure you have a lot of questions regarding the lecture, and we're all interested in your lecture as well. Do you have any question for Linda, Vincent?
First of all, I would like to congratulate Dr. Linda's work, and as well as her presentation. It was wonderful to listen to your presentation, Dr. Linda. And I have only the my opinion about the presentation. I don't have any specific questions, but I really enjoyed your presentation.
Okay.
Thank you very much for that complete overview, and you did full justification within that 20 minutes. And I would have sat and listened to your lecture for another hour.
Thank you, sir. Thank you.
Excellent, excellent. I would like just a quick glimpse, if you like, to elaborate about compression garment in the arm, Linda. You mentioned that the more we know, the more we need pressure to be on the deeper tissues rather than the one we have at the moment. So what do you think the pressure garment we have at the moment, and how can we increase, or there is a message to industry in order to fulfill the criteria that we have learned from research?
Yeah, that's a great question. I think that one of the biggest issues with any of the applied techniques, garments or bandages, is are they difficult to apply? And so, although we know that higher pressure, higher compression may be better in terms of maintaining filtration or decreasing filtration, we are still limited by that patient being able to get the garment on. So what I would suggest is that, again, the garment is one of the pieces. We can be more aggressive with managing filtration with a compression pump, with exercise, and with a garment. But we may, until someone comes up with a very creative and effective way to put on a high pressure garment, we may still look at that and still have issues with filtration. To that point, though, Dr. Omar, I would say that the literature right now on compression garments as a maintenance is actually very good. And so the pressures that we're using, once we get rid of a lot of that extra filtration that's already there, the current pressures we're using seem to be effective enough to prevent further filtration or minimize further filtration into the tissue.
Excellent, excellent. And do you think pre-operative garment application before the mastectomy, will this play any role in preparing the arm for the post-operative, or there is no evidence scientifically for pre-operative garment usage before mastectomy?
Yes, there's very little evidence for pre-garment use. However, I want to qualify that by saying, now that we know that Dr. Mortimer and others have shown us that there's increased filtration of lymphatic fluid in both arms of women preoperatively. Okay, so now we're looking at the group that you're talking about, preoperatively. Women have increased lymphatic flow preoperatively. That might be a subset of women who would benefit from wearing compression prior to surgery. Until that literature came out, intuitively, it didn't make any sense to wear preoperatively. But knowing that there are some hemodynamic imbalances that are there pre-existing, as Dr. Mortimer and others have shown us, then wearing a compression garment may be appropriate for those patients. Determining who those patients are is going to be challenging.
Excellent. So I will take a few questions from the attendee, and then I will give the mic to my dearest Bethanie Noll to present the next speaker. So the first question we got from Dr. Ahmed Abu Zaid. He said to Linda, what about lymphokinetics or induction devices beside nutritional dietary supplement? I think he's speaking about the devices like Lymphotron and other devices that will help with dietary supplement for lymphedema.
Unfortunately, that's probably one of the weakest areas of my knowledge base is dietary supplements. So I don't have an answer with regards to that. I'm sorry if anybody else could maybe add to that, but I am not well versed in that.
Okay. Vincent, do you like to add to this question?
Yeah, like Linda, it is not my strong area of, we are all physios and researchers
Exactly.
working. Yeah. So
yeah, I
really
think up till now it is still investigational. If we can have a dietary, a low protein diet that will affect lymphedema, at the moment there is no clinical evidence that it play any role. Same with micro lymphatic surgery, where they used to anastomose lymphatic, microlymphatic lymphnode anastomosis and lymphovenous anastomosis is still under clinical research. So I think I totally agree with Linda and Vincent that there is no evidence so far. We just, I think that this is what is evidence-based lecture. You want to give us the current recommendation with good evidence. No nutritional good evidence play a role, and so micro lymphnode anastomosis, which is a nightmare to do if you want to anastomose 1 millimeter lymphatic to another 0.5 millimeter lymphatic. It's nightmare. So another question, which is about radiofrequency. Are there any radiofrequency source besides stimulate the changes in tissues or venous tree? Again to Linda. Radiofrequency sources. Yeah.
Well, I'm not sure if this would be consistent with that, but I know there is some research or some very preliminary data that's coming out using vibration as a technique. Again, it's not been scrubbed well in the evidence-based community.
Exactly.
But the exciting thing I think about it is that by the more we understand about the pathophysiology, the more our brains are going to be thinking outside the box about, hey, well, what about if we want to change tissue pressure? How about vibration? How can we do that in an appropriate way? So I know that there's not strong evidence, but there are some very hardworking clinicians that are developing new devices to actually help with these conditions.
Yeah, excellent. I will take one final question. Dr. Helmi Rashidi, question to Linda. For lymphedema patients who are on compression garment, do they need to wear it 24 hours in a day or need to take it off during the night? I think you answered this question, but like to have it again.
Sure. For the most part, I think the standard has been that patients will wear the garment during the day and take the garment off at nighttime. Certainly not wear the same garment that they've worn all day and wear it all night. So the recent study that I reported was from a Canadian multi-center trial that looked at women who wore their garments during the day, and then the 3 arms of the wore no compression at night, bandaging at night, or some other nighttime compression. And what the study found was those that did some nighttime compression, whether it be by bandaging or a nighttime compression system, got better volume reduction than those that didn't compress at nighttime. So if you have a patient that can tolerate compression 24 hours, of course, they always need to be able to have a break, but some of the current literature is suggesting that daytime and a different form of nighttime compression may be beneficial.
Okay, I'll take another question because I was told we have plenty of time. Do we need an oncology? A question from Puskas Attila. Do we need oncology approval before manual lymphatic drainage, MLD? I think it's also an important question. Do you need to get oncology approval or not?
Well, the simple answer is no. But I have a follow-up question that I may be reading in through that, and I'm not sure. Is the question based on the fact that there is fear that we can spread cancer through the lymphatic system with our massage technique?
Exactly.
Metastatic disease is another one of my passions, and I've traveled the world to hear people lecture on breast cancer metastasis. And I can say this with full confidence to the clinicians out there. We clinicians are the only ones that think that we can spread cancer with our hands. I remember speaking with the head of the NIH, which is National Institutes of Health here in the United States. And I mentioned to him, we're concerned about modalities, for example, using heat, using ultrasound or massage. And he wrinkled up his face and he said, "You guys believe that?" And I said, "Well, it's in our literature." And he said, "Linda, if that were true, we wouldn't be having these robust discussions on metastasis. And it would be very simple to figure out how not to spread disease." So I just, it's a common question that comes up. There actually has been at least 2 studies that looks at manual lymphatic drainage and spreading metastasis, and both studies have demonstrated that not to be the case. Okay, so again, it's difficult. They're not randomized controlled. They're not large studies, but it's been looked at. It's a good question, and I really am glad it came up in this lecture.
Yeah. So I will take one final question, and thank you very much for this beautiful answer. This question is from Dr. Shuruk Rice. She said, "Thank you, Dr. Linda, very much for very challenging with our patient using garment, and so it is difficult to apply most of the day. So in your clinical practice, how many hours of using garment daily is effective?" Again, it's a good question. Do you think 18 hours, 16, is it below 12 not effective? Do you have any rough figure from your vast experience?
I don't have a hard and fast figure, and I think part of this goes back to as the literature begins to come out. So, for example, Dr. Johansson's literature on garments and with early breast cancer, that you might be able to titrate a patient off of compression as the limb gets better and as their lymph system is able to handle the filtration load on their own. Okay. However, you might have the opposite, where you try to titrate a patient and the limb volume increases too much. I think the important thing, and for me as a clinician, this is why I'm actually giving an amount of hours, is because compliance is going to increase with the best techniques that make a difference, and what's the least amount that a patient needs to do to get the limb down and keep it down. So I am constantly titrating different modalities that I may be using, including garments, with regards to how much time. Some patients may need to use a garment only when they exercise, and that could be very controversial. Some actually use it 8 to 12 hours a day, some 4 hours. What I am learning, the longer I've done this, is that there is not an answer to the static nature of any of these applied pressures.
Excellent. This is the best answer. Thank you very much, Linda.